Okay, so this is the first case. This is a case we did about a month ago, right after American Heart. And this is a case you can see here, right coronary CTO. It's fairly calcified and seems to have some good collaterals from the left coronary. So again, for people who are joining us for the first time, I see a few people who haven't joined us before, feel free to, this is very interactive, and the whole point is just to have everyone give their thoughts and questions. This is not a formal meeting by any means. So how would people approach this one?
Well, it's a short, seems to be a rather short occlusion with good distal flow and not at a bifurcation. So I'd probably try after wire escalation. If it didn't work, consider antegrade dissection reentry.
And does it bother you, the fact that it's very calcified distally, and you have all this calcification in the distal part of the vessel?
I'm sorry, I didn't quite get the question, Manos.
So this is a very calcified artery. And, you know, the problem with that is if you go subintimal, you might have a little more difficulty in the entry. Would that, I guess, would that be a factor in choosing the initial strategy, or you would still go antegrade wires anyway?
Well, I think your point is well taken. And of course, that's what you said is correct. So I think I would probably, since the occlusion is short, try an antegrade approach first.
Sure, and I completely agree, actually. That's what we did here. So again, for people who are familiar with this, this is the algorithm that is called the hybrid algorithm, currently used for most cases, and for teaching purposes as well, where we start with a dual injection. And then if you have an ambiguous cap, or the vessel distal is bad, and you have good collaterals, then you might go primary retrograde. But if you don't have any of those factors, then you go antegrade. And because here, as Barry said, this looks like a short occlusion, then you would try the wires first. And if it didn't work, then you would try the antegrade dissection reentry. And if everything fails, of course, then you still can switch and go to a different strategy. So this is exactly what we did here. One of the difficulties we had actually in this case is very hard to engage with the guide catheter. I think we tried 6 or 7 guides, AL1, AL.75, XB, IM, TAMP, and I think the final one we're able to work is this one. I think it's an AR1. That's the only one that can actually get to engage the right coronary. So what we have here is a Corsair, and we tried several wires, Filter XT, Pilot 200, Confianza Pro 12, the full escalation algorithm, and nothing seemed to go. I think part of it was that the vessel was very calcified. And then, as you said, we just try also the CrossBoss. And again, I think CrossBoss is one of those areas where if you have a lot of calcium, it might be a little hard to go. It tends to click a lot and needs a lot of support to be able to push through this. So I'm not sure it's the best approach, but we'll try it anyway. And same thing would not really get through. So any thoughts at this point? Actually, it's a good view because it shows some of the collateral as well.
Yeah.
So again, and that's an argument. So the problem here is we tried antegrade. We tried both with a wire. We tried with the CrossBoss, and we don't make any progress. So that's the importance of knowing retrograde, because in cases like this, where nothing else seems to work, then retrograde can provide you a nice bailout option. And you see pretty decent collaterals. Interestingly enough, I think our wire is actually not in a good collateral. Can people see the movie? Is it may not be most clear, but
yeah.
So we're able to get through, and as you see, there's a bunch of collaterals, CC1 meaning connection all the way down, and some CC2s as well, so nice, more than 0.4 millimeters. And I think this is, interestingly enough, when we went with the wire, I think we got through a smaller one, not the bigger ones who thought they were going to be a successful one. Okay, so we're able to get through the reverse card, externalized balloon. And it looked a little difficult, a little suboptimal distally, put another stent over there. And then took the stent balloon and took it for proximal.
Oops.
And we did a final dilation just to make sure everything looks good.
Doesn't look too good.
I think we all agree. Well, the interesting thing about this is we haven't had a perforation for a long time. So I was like, well, perforation is very frequent. We don't really see it very much. And then there you go. And then I think within like 3 months we had 2. So I think it's one of those things. You don't see it for a while, but then you might see something. I think the bummer in this case is if you perforate when you're trying to cross or in the reverse card, I understand this. But this one was kind of a weird one because the perforation happened because of a balloon rupture at the very, very end of the procedure. And now this was a very complex, this was I think 3 or 4 hours in the case. We thought we were done. We're very excited. I mean, it was all, ready to wrap it up. The balloon ruptured and then we have this.
It happens after, so post-dilatation. That's when it happened.
So actually it happened, post-dilatation, but then the balloon ruptured.
I see.
So, I mean, it's hard to know what did it. My theory is that when the balloon ruptured, you get some focal jet of contrast that potentially, and this was an area of reverse scar. So I think it was weakened to start with.
Yeah.
So maybe that's part of the reason why we're having this difficulty, but that's the thought.
And you don't think you have gaps there? The whole thing is stented.
Yeah, everything is stented. So all the way from down here, all the way up to essentially the ostium of the right now, everything is stented. And we do have an externalized wire, so have tremendous support to deliver stuff there.
And your ACT,
we still haven't pulled anything out.
Yeah, you're actually though, in one sense you're in pretty good shape because you can occlude that area with the balloon first, and then you have the second access site there already, and you can put a second guide into the right coronary area so that you can maintain occlusion of the perforation while you put a second system in to allow you to put a covered stent in that area. So that's the good part of this perforation at this point in the case. Did I make that clear, or was that too confusing?
Yeah, that's a good point. Now, the challenge here is that we have externalized wires, so both guides, both femoral guides, they are both used, part of the rail. So to do this, we would have to get either a brachial and get a big one in, or get a radial and put, now with the new cover stents, we can get 6 French, all you need for the new cover stents. You don't need 7 anymore. It's monorail, and they're 6 French up to 4 millimeters in diameter.
So Manos, how those are all good thoughts. How did you manage the anticoagulation here, knowing that you have still a wire in the left main and LAD, and I'm sure you're thinking about reversing here with protamine. Did you do that, or?
So I did it initially, and there is this theory that you don't want to be reversing too much because you make a lot of your guides, especially here we have a retrograde wire coming into the septal, LAD, left main. So I did it initially. Actually, I'll show you. Eventually I did. But I was hoping to contain it initially without reversing the heparin.
Okay.
But you're right. It's one of the things to think sooner rather than later, and try to do that if you can. So
I guess I was thinking about this. Why couldn't you put at this point in the case put a wire antegradely with a balloon and just stop the flow there? I mean, and then you can take out your you can take out the wire that is externalized and take it out, and then use that particular access to go in and fix the perforation, because you don't need anything retrograde anymore. If I'm not correct.
True. I agree with you, but I guess what you're saying is maybe we have the guide, maybe put this Antegrade guide, you can put a wire through this.
Correct.
So you don't have to actually pull the retrograde wire out. You can keep that. Actually, one thought that came from a colleague is, retrospectively, put a balloon retrograde and tamponade retrograde, and then get a wire through Antegrade and deliver the cover stand that way.
Yeah, that would make sense also. That would be a good way to do it also.
However, the issue we had is I could not get, so actually initially it was fairly contained. I was able to get the balloon down for a while. So, and if you look at the picture, although it looks pretty ugly, it's not free flowing into a cavity. It's going into some sort of structure. And actually on echo, we did an echo, it was a hematoma on the artery wall. So it's obviously it's a big curve, but it's not exactly free flowing into the pericardium. So going down with the balloon for maybe 20 seconds a minute might not be as catastrophic as in an otherwise massive large perforation.
How is he doing clinically?
He's stable. No, he's having some discomfort, but blood pressure is holding.
Did it cross your mind to just, I mean, it looks like a large perforation that even with the balloon inflation, it probably won't seal completely. Did you cross your mind to just go in with a cover stand and fix it?
Yeah, so that's the first thing we want to do. Now, some of the background on this. The cover stands cost close to $3,000 a piece, expensive. The VA has a limit on the order. The net result of this is, at this point, I have a single cover stand in the lab, a 3018 cover stand, or 16. That's it. Which I tried to get down, and the whole thing crumbled like crazy in the ostium of the vessel. In spite of having a externalized wire, tremendous support, we did have a lot of difficulty there delivering anything from the beginning, but the stand was destroyed within 5 seconds.
Great.
And that's our only cover stand.
Not good.
So yeah, not good. Not good. I would agree. Now, another option, if we had another one, and people suggested that as well, would be to get a guide liner down and deliver the cover stand with a guide liner. But here we have the same situation with the guide liner not being able to go down because of the difficult engagement, calcium on the ostium, and the loss of stents that are now in the right.
Well, I suppose you could put, I guess, a little tube into that. That's a pretty big neck, so you could put a tube into that neck and consider putting some coils in. Oh,
into the perforation side. I see what you're saying.
Yeah.
I guess that would be an option. To be honest, it didn't cross my mind at the time, but that sounds a reasonable option. Although the space looks a little big, I don't know about the space looking a little generous. But I guess that's something definitely we can do. And then the neck is wide, so the concern there will be, will the coils want to come back towards the
struts,
the main vessel?
Yeah, except that you have a stent there.
True. And then I guess I can put actually we did end up putting another stent. I can put another stent, just double jail it or something like that.
Yeah.
So going on this, so against the large vessel perforation, what we did is we cut the balloon up again to stop the bleeding. We did not reverse because I was hoping to control it without reversing the heparin. we did an echo, and he did have a trivial effusion, so it was a very small effusion, so we kept on holding. And we did have contralateral access, so we didn't do this. And then the next thing was to try to deliver a cover stent, but the cover stent again crumbled. And this is the cover stent. By the way, I don't know how many of you have the new cover stent in your lab.
What's the new cover?
So there's a new monorail cover stent. The Joe stent now comes into two versions: the old over-the-wire version that requires 7 friends guide at least, and it's over the wire. And the new monorail version, which is the one shown here in the picture, that actually has monorail and it requires 6 friends guide for up to 4 row stents, and then 7 friends for the 4.5 and 4.8 stents. So actually, that's a big improvement compared to what we used to do before. The delivery system, they say, it's much better. And the stent is a little more flexible, a little better deliverability than the previous version. So does everyone have this in their labs, or?
Yeah.
I don't, but thanks I am glad you told me. Thank you.
Yeah, and the only reason why I know is not because I've used it, but you need to get a new IRV to get it. And so, because this is not approved for clinical use, so it's supposed to be a research stent. Yeah,
for both though. This one and the old one, both of them are research stents.
Yeah, but you need to get a new application to get the new product. That's what I was told.
Yeah, what we did actually, we just told our RB that the new version, it actually allowed us just to put it on the addendum for the old protocol. Didn't even have us make any submission, just addended it on the old protocol.
Yes.
So it was not that painful, but definitely a good thing to have. And again, because it's expensive, you may want to talk to your cath lab manager to get it on time, because it's hard to get them with the new restrictions on purchasing. So in any case, so at least I think it was at least 2 hours I spent ballooning, and we actually ended up putting another stent. So put an extra layer of stent. There are some reports out there that if you don't have a cover stent, if you put a second stent, maybe it'll move the tissue or cover something or help you get hemostasis. And I can tell you it didn't work. There's the other opinion saying that if you do that, you may actually pop open an existing plane and make it worse. Again, in this case, it didn't do better or worse. It just kept on bleeding. So I don't know if any thoughts right now. So we're now probably 4 or 5 hours into the case.
And have you reversed yet?
Not yet. The ACT by now was around 250. So it was about 360 or so when we started, more than 350. And then now it had come down to about 250 or so at this point.
I would also second this issue about dealing with reversal, because we did this. We had a case where we had a perforation where we reversed, and it was really terrible trying to get rid of all that clot that developed after that. So I think once you commit to reversing, you really have to really anticipate that thrombus might develop.
Yeah, that's a good point, and again, especially with an externalized wire. So after I reversed, after I removed the wire from the LAD, the left main, so we don't have any issues there, clotting off there.
Yeah.
I mean, right, if you close it, maybe not as horrible, but if you close the LAD, obviously, then that's going to be pretty catastrophic. So, the other thing here, at this point, the blood pressure was getting a little lower, probably in the 110s. It was 160, 170. It started with 110 or so. So pressure was getting a little on the lower side, and on the echo there was a little more effusion. And I must say, initially I was hesitating draining the effusion, because the theory is that if you have a little bit of blood in the pericardium, then what happens is it helps you tamponade the occlusion, where if you drain it, it may bleed more through that perforation side. I don't know if anyone has that theory. Obviously, if it's hypotensive, that's not an issue. But if you're kind of borderline, trying to hold off tapping, at least from the beginning.
Oh boy.
And again, keeps on going. As you see, no, if anything, there's like 2 basal craters coming out there. And to be honest, I think part of the issue here must have been the reverse card. Because I think in an otherwise, let's say it was not a CTO, the chance of bleeding so much from just the channel, that might have been not as high, I think, as it was in this particular case. So at this point, what we did end up removing the retrograde guide wire. And again, we did some more balloon inflations. At the time, actually, to do this, we had the balloon down for a little while, and he did tamponade. So we put in a pigtail in. As you can see, we have a pigtail now in the pericardium. And then we reversed with protamine. And after we did that, actually, it finally sealed. And the patient did well, actually. He was stable, no more effusion after this. We pulled the pigtail the following day, and he went home a couple days later. But again, that was probably the worst perforation I've ever had. It's interesting that everyone says the cover stent is a solution. That's true. But what at least my impression of here was that the cover stent may be very hard to deliver, especially in those CTOs with all this stent and calcification and tortuosity and things like that.
Yeah, a good say, man.
So again, I guess the bottom line is, I think what do you do in this case, long balloon inflations, we did call the surgeons, which they were not very excited about going in. But anyway, I guess it worked out well in the end. Now the surgeons are telling us that he's going to form an aneurysm there, and we should bring them back at a few months and check it again. I don't know if any thoughts of anyone. Have you seen perfs like this evolving to aneurysms down the line?
No, I've seen one case in Piedmont when I was starting doing this. Last case, they think they did like 8 cases in 2 days. The last case, they were, celebrating opening the champagne, and they did pictures, and they got exactly the same picture you show us today. So, and it was a reverse card. So I think you're right about the mechanism of the perf. I think these vessels are just not. They're so diseased that it's hard to get a good result at the end.
Yeah, so again, I'll let you know. We'll bring him again back in 6 months from this, so probably in May, and see what we'll find. But this was an interesting case, I guess. And again, I think that's what Barry was saying earlier on. Normally, in this case, what you do is you get a second guide. You put the balloon first to stop the leaking. You get the second guide casted in, and then deliver the cover stand over the second guide. This way, you minimize the time that perfusion, the perforation is leaking blood into the pericardium. So dual guide technique. And again, with CTO, it's not very hard to do because you're really going to have 2 guides anyway, so it's not a big deal for CTO. It might be more of an issue to have a non-CTO, but then get the balloon up and wait and see what happens, and then with the cover stand, hopefully that will take care of that. And interestingly enough, so that for we look again at how often this happens. And again, it looks like it's not that common. The tamponade is about 0.3% of CTOs get tamponade. So still not zero, but not very high either. And we're just looking at this at MCDR. And apparently it's double perforation rate, double tamponade CTO than non-CTO, which I guess makes sense. I mean, you're more likely to get perforation and possibly tamponade if you do CTO than non-CTO intervention. Okay, and this is again the book that many of you have helped us do, so very appreciate that. And this is another case. I hope I can show you here. Yeah, I'm sure there's some issues here, technical issues. Okay, there you go. Well, actually, first, I don't know, many of you may have seen this, but I want to show you a testimonial. So we had a patient, our vision asked us to take some testimonials from patients, and we did this testimonial from a patient who got CTO angioplasty. Okay, so that was, again, one of the patients. And I think, for every program and for every one of you, if you have people like this that get benefit, it might be a worthwhile thing to have a video like this, even to show to other patients or to show to the administration sometimes. So I don't know what your thoughts are, but this has really helped. Administration was very happy about this. That's the ones who asked for it. Okay, so I don't know if you can see it now. So this is another case, again, right coronary CTO. About 50% of our CTOs are right coronary, 50-60%. And this is one of those classic cases, proximal RCA, feeling retrograde from the LAD, and then we'll have an occlusion that's probably from the proximal to the mid segment of the right coronary. It comes back quite a bit. And this is, again, similar view. You see the context coming way back, but still it's at least 40-50 millimeters of occlusion. So, any thoughts about this? Go primary retrograde or primary antegrade, or
it's a little hard to see, Manos. But it looks like there may be a little nipple after that right ventricular or right atrial branch comes off, which may represent a continuation of the RCA. So it may be worthwhile to try antegrade approach first. But it's a little hard to tell based on looking at these pictures.
Yeah, again, I'm sorry, we've had this issues today with film. Let me see if I can make it improve a little bit. Okay, yeah, I'm sorry. For some reason today it's been a little hard with the audio visual, but so again, the same thing here. And I agree with you that we'll try Antegrade first because we have enough, and maybe the secondary entry might work. And we have the same thing here. We do have a proximal right occlusion. So this is the fine cross. I'm sorry, it's a Corsair with Fielder XT, which you may be able to see is actually going way out from the pericardium. again, reinforcing, dual injection is a problem. So we tried Antegrade, it didn't work out. And then we tried to use a CrossBoss catheter as well.
Manos, my picture has gone away. Is your picture there?
Oh, okay, I'm sorry, let me just double check here. Did you come back?
Yeah, I came back.
Okay, yeah, sorry for that. So again, Antegrade wire didn't work, and CrossBoss didn't work either the first time. And this is, again, same thing as the last case. If one doesn't work, try to do another option. So we had different collaterals here, and we thought it was going to be fairly easy to get through. And we're trying to get now down the collateral there. However, as you can see, it looks fairly decent in this area. But I spent probably an hour and could not get through these collaterals. And you'll see here the wire would go down and would just buckle just before getting into the PDA. And even in Japanese hands right now, I think the rate they quote is 80% crossing success. So 20%, 1 in 5 collaterals people cannot cross either because of tortuosity or not a good channel or other problems. So this is not frequent, but it can happen. The advantage though with retrograde is that we save contrast. So you can do surfing without using contrast, just try with the wire or do injections through the microcatheter. So with the case yesterday actually, in a patient with a creatinine of 2.2, GFR of 35, we do it with 100 of contrast because the retrograde, once you get down, then you don't have to do contrast injections. You can just do the reverse card, standing everything without injecting contrast at all. So after it failed to go retrograde, then the next step was to put we'll try Antegrade again. Again, CrossBoss didn't work the last time, so we tried with the knuckle. So this is the Corsair catheter together with Fielder XT wire. And I must say, increasingly more so, I'm using the XT for my knuckles mostly because the Pilot 200 is just too big. It makes it a very large knuckle. It makes it a little hard to do this. So I'm using XT more and more for my knuckles. And unlike the case, if you can see the movie now, the knuckle is moving nicely next to the vessel wall with a contralateral injection. So it looks like we're in a nice location. And this is the re-entry spot, Stingray wire. You can see we're unfast. We see the railroads. Probably it's hard to see in the other monitors. This is very, very small. But we're able to get through into the distal right and confirm. You actually see a little bit of stain in the septum. That's from the failed retrograde attempts. And again, most of the CTO group advised against injecting from microcatheter. I think here we were still a little nervous because it was a very small, diffuse disease vessel. That's why we did it. But for most purposes, it's best to not do this injection. And then we switched for a workhorse cyclic soft wire, whatever workhorse wire you like, and it worked out well. And this is actually a paper we just got out, accepted as the Journal of Interventional Cardiology, because many people are saying, how often do you need the hybrid? How often do you need the change? And the reality is, you don't need it very often. So in about 60%, 55% or so, you go, the first approach succeeds. So you don't have to go with the second approach. So it's in about 44% you need to do this approach changes. So it doesn't necessarily mean, that you're going to do these, you're going to suffer forever. And the same thing, this is from, again, the registry. Santiago is helping us very much, and we appreciate it. showing that out of about 500 cases, again, the initial success about 60%, about 60 for Antegrade, 64 for sex-oriented, and 70% for retrograde. So off the bat, the first approach you do, 60% of the time you're going to be successful, and then you do everything else, you get to this 90% level. But the first approach will be successful in almost 2/3 of the cases. So that's another important point. You don't have to do all the techniques in every case, but in most of them you'll be successful in the first case. I don't know everyone's experience, but to me it looks like this is becoming more and more relevant. And again, same thing here with the prior conduct test. Great. Well, again, I think I'm going to stop over here. No more cases for today. Thank you very much for being on the call.